This is a live recording from Radiopedia.org's 2015 Emergency Radiology course in Melbourne, Australia, featuring Dr. Andrew Dixon and Dr. Frank Gaylard. For more information about Radiopedia courses, visit radiopedia.org/courses.
The abdomen is very much focused on CT, and I just want to say at the start that I know where the pathology is, so I'm scrolling down fairly quickly to get to it. I'll try and point out some of the stuff and my thoughts as I'm going, but we don't really have time to be going through everything in a systematic approach. So that's the reason why we give you access to all of the cases, so you can look at them in your own time and work your way through them. So you might feel like you're getting a little bit dizzy as I'm scrolling down and pointing out the things, but I'm just trying to get through the important findings and pathology, and then you can take your own time to work your way through every image.
I might just have one question that I've been wondering about. It relates to the chest and the abdomen of CTs, and that's the use of IV contrast. And what's your cutoff creatinine? Do you have one, or EGFR, or anything for using IV contrast?
So Andy's asking about intravenous contrast for CT patients and a cutoff level for a renal function before you would stop giving the contrast. This is something that I think has changed in the last 12 months. There was a paper published in the journal Radiology last year, which basically compared, I think it was 12,000 people who presented to a hospital needing a CT scan, and they followed them and had a look at their renal function, their EGFR, and then they tracked the patients and saw which ones went into acute kidney impairment, because that's what we're worried about with contrast, and the ones who didn't. And then they actually found that the patients who had poor renal function before they had the CT scan were more likely to go on and have an episode of acute kidney impairment afterwards. Okay? But what they found was that people who received no intravenous contrast and people who did receive intravenous contrast went into acute renal impairment at exactly the same rate. Okay? So therefore, if you're an unwell patient presenting to hospital and you need a CT scan and you've got bad renal function, then you're probably going to go into acute renal failure. It doesn't matter if you get contrast or not. Okay? But this is just one, it's a very big study, a very good study. There's still some debate, and so the practice, I know since that study's come out, my practice has changed. I'm much more lenient on giving contrast to patients where their renal function is poor. We're talking about, it used to be about an EGFR of 60, where you would say, let's go without IV contrast. There are obviously studies like a CTPA where you can't do it without contrast. Okay, so there's a little bit of leeway to do with the clinical setting. Okay, then there's things like giving N-acetylcysteine and pre-hydrating and post-hydrating the patient. And so we used to be around about a 60 with a few little tweaks around the edge, then down to about 45 with some tweaks around the edge, and now we're getting even more lenient with it. But it's an evolving area, and so I think when you're requesting a study and you know they've got bad renal function, you may find yourself having to debate a little bit with the radiology staff. It's still ultimately up to the radiologist. We're the ones who are administering what is a drug to the patient, so it's up to the radiologist to decide what their level is. Okay, but that is definitely something that's changed in the last 12 months. Okay, abdomen. Plain film to begin with, just some normal anatomy of the abdomen. I also want to point out some large bowel. Here you've got those big haustral folds in the large bowel, very separated by a few centimetres. Okay. In the small bowel, which we can't really see a lot here, you have those really tightly packed mucosal folds, the plicae circularis or the valvulae. So you can identify large bowel versus small bowel because of that mucosal fold pattern. Okay. Also, the large bowel tends to go picture frame around the abdomen, transverse colon, descending colon, down to the sigmoid and the rectum, whereas small bowel is largely centred in the centre of the abdomen. Okay, so that's a way of identifying between the two. On this case, I want to emphasise it's another thing about the silhouette sign, or being able to identify the interface between two structures. You can identify bowel loops on an abdominal X-ray because there's gas inside the lumen, and it's a different density to the mesenteric fat and the bowel wall and things that sit outside of it. Okay, so you can see the interface between the lumen and the wall of the bowel. Okay, the lumen and the mucosa. But you can't see the interface between the edge of the outside wall of the bowel, okay, because the density between the wall and the adjacent fat is fairly similar. Okay, so you shouldn't be able to identify that. So you look at all these bowel loops and you can only see the inner aspect of the wall. You can't see the outer aspect of the wall. This patient's not completely normal. They have an abdominal aortic aneurysm. You can see this calcified thing coming down here. Now here's a patient who has a, I think they're post-op, they have pneumoperitoneum. On our chest x-ray, a direct chest x-ray, we're looking for this little bit of air sitting under the hemidiaphragm. Hemidiaphragm is a really thin structure, a little bit of air between it and the liver in an erect patient. But a lot of the time when we're doing supine abdominal, we're doing abdominal radiographs, you don't get an erect. Most of the time, most patients just receive a single supine film. And here's a nice example of being able to see the inner aspect of this bowel wall. So here's the mucosal aspect, but also you can see the serosal aspect. Okay, you shouldn't be able to see that. Seeing both sides of the bowel wall on an abdominal radiograph is a sign that there's free gas. Okay, so that's a pneumoperitoneum. This is called the Wriggler's or Wriggler sign. Okay, so there's the arrows. It's a very handy one to be aware of, the Wriggler's sign. And again, it comes back to that. You can only see an interface between two things if there is a significant density difference between them. All right, so this is a normal scan of the abdomen. I'm just going to point out a few of the structures. Obviously, we have the liver up here, portal vein coming into it. We scan the abdomen usually during the portal venous phase, so we've deliberately timed it. So we've got contrast coming through in this portal vein, more so than in the aorta. That would be an earlier arterial scan. And you get this nice, fairly homogeneous appearance of the liver, nice density. Same with the spleen. If you scan it during the arterial phase, you get this blotchy, swirly looking spleen. If you do it during the portal venous phase, you get a nice uniform spleen. Okay. Pancreas is difficult to trace. This is the pancreatic tail. It always starts up near the splenic hilum, so you can start finding it from there if you want. And then the pancreatic tissue comes along here, comes down here. This is towards the pancreatic head, this stuff here. It's a tough organ to trace if you're not experienced, okay? Adrenal glands is something that people really, really struggle with, and I think it's because Netta drew them as being these nice little blobs sitting up on top of the kidney. So this is the adrenal gland here. See that little thing sitting out in front of the kidney? So that little linear thing there, it's got a medial and a lateral limb to it. Okay, it's a little bit pyramidal in shape. On the other side, it's this tiny thing here. See that? That little thing. So that's the adrenal glands. I always routinely look at that on every scan because you will find metastases go there. Trauma patients' adrenal hemorrhage is something that can change management of patients. So important structure to identify. Okay, gallbladder here, sitting underneath the liver. I just want to point out a nice fluid density. Okay, fat density black, fluid density grey, enhancing parenchyma inside the liver, nice and bright. I want to point out, see just the slight brightness to the wall of the gallbladder? That's the enhancing mucosa, okay? It's really, really thin in a normal gallbladder, really thin enhancing wall, nice black pericholecystic fat, okay? Kidneys, nice looking cortex and medulla. The looking for hydronephrosis is something that we'll teach you shortly. The renal hilum contains a renal pelvis, ureter that comes into the renal hilum, and then you have little calyces going out into the kidney. And then you should have this black fat. See that black fat sitting next to it? That's renal sinus fat or hilum fat. That's normal. If you've got hydronephrosis, you completely efface that fat. That fat goes away, and these little calyces start to dilate up, and the renal pelvis becomes massive. You see how you've got nice black fat coming in through this kidney? That's a sign that there's no hydronephrosis. Here's the little calyces going in here with little black fat around it. Okay, seems to be a little bit duplex, this one. You can see that two pelvises coming together. So that's the kidneys. We'll learn a bit about tracing ureters later on when we get to renal colic. Other organs, the spleen we've been through. Small and large bowel, takes a while to learn how to trace that, and it's not necessarily important in every single patient to be tracing the full length of it, but we'll go through some features that might catch your eye with the bowel later. The appendix, it's always worth trying to identify the appendix if the patient has one. This is it. Down here it's got air in it. Okay, blind ending, tubular structure coming back to the base. Let's just follow it back, coming back here to the base of the cecum. Okay, so curly whirly thing, nice fat next to it, not inflamed, bit of air in it so it's not completely obstructed. If an appendix obstructs, the air tends to get resorbed. Okay. A trick to kind of finding it is to identify where the ileocecal junction is, so where the ileum comes in here into the cecum, and then just look a few centimetres below that and you usually will find your appendix coming off. Okay, so that's it coming off there. Free fluid is something you need to know how to look for. This is this patient has, I think it's a woman, but she's had a hysterectomy, but you're looking for fluid sitting anterior to the rectum or the vaginal stump here and between the bladder. Okay, so fluid sitting in this space here. If you've got fluid sitting out here in front of the sacrum, presacral space, that's extraperitoneal. That's, pelvic fractures, something in the retroperitoneum tracking down. That's not free intraperitoneal fluid. All right. The other place to look for free fluid, Morrison's pouch. Again, the ED physician's looking for their free fluid in a fast scan. This is where you're looking next to the liver and the kidney, Morrison's pouch. And you'll usually detect it really, really easily next to the liver, between the liver and the hemidiaphragm, a small volume of free fluid. Let's move on to some pathology. And we're going to play a game called Speeditis. It's a registered trademark. It's a new, so it's another poll. So if you can have a look at your poll options. So the poll options are diverticulitis, pancreatitis, appendicitis, gastritis, and pyelonephritis. We're in the itis section of the talk. And this is actually a game I sometimes play with my registrars because you can actually spot where the abnormality is relatively quickly if you know what to look for. So let's have a go. You ready? It's going to be pretty quick. They're the options. Everyone ready? All right. How'd you go? You want another go? You want slower? Oh, come on. Has anyone spotted it? Anyone confident they know what it is? All right, vote. Let's go. Oh, look, you do know what it is. It's pancreatitis. Good job. All right. So, with itis, the point I want to make about itis is it's the same really everywhere in the abdomen. When something gets inflamed, it gets edematous. Fluid is a little bit lower density than your normal enhancing parenchyma, so it's going to reduce the density of that organ or structure, okay? And it's going to get enlarged because it's swollen, it's getting edematous, and the fat around it is going to get inflamed, and because fat is dark and edema is a little bit more towards fluid density, it's going to create this increased density in the fat around it, a little bit of what we call fat stranding, inflammatory stranding, okay? So this pancreas, this is a bulky looking pancreas, okay? Slightly lower density than most pancreases that we see, particularly this area in the head here. And look at all the stranding of the fat next to it, okay? Ill-defined margins, all this stranding. It's a retroperitoneal structure, it's in the anterior pararenal space. So you don't usually expect to get a lot of free fluid associated with it, but you do expect to get some stranding, tracking in the retroperitoneum in front of the kidney here, tracking right out into the paracolic region, okay, retroperitoneal. Remember that the small bowel mesentery is also kind of it's rooted in the posterior, in the retroperitoneum, so it comes forward. So it's very common to get this stranding coming out around the small bowel mesentery because it's really a retroperitoneal structure or an extension of the retroperitoneum. Down in the pelvis, we're seeing just a little bit of free fluid. You do get a bit of reactive free fluid in these patients. Okay. So pancreatitis. The key with pancreatitis, I think we've got another, no, we haven't got another patient. The key with pancreatitis these days is they're often doing an early prognostication CT to try and predict any complications. And you want to do it during the arterial phase or a pancreatic parenchymal phase, so you can really assess whether the whole of the pancreatic parenchyma is enhancing normally. If you've got necrosis, then obviously that's a bad prognostic sign. You also want to assess the superior mesenteric arteries, make sure there's no splenic arteries, make sure there's no pseudoaneurysms forming from the inflammation. You want to make sure the portal vein's enhancing, okay, because you can get portal vein thrombosis as a complication. This is worth noting. See this patient's gallbladder sitting here. So how earlier I said, you have that mucosa enhancing. You just see a little bit of thickening around. See that little extra edge, extra line outside the mucosa. A little bit of wall thickening, a little edematous. Very common for the gallbladder to get inflamed secondarily to an acute pancreatitis. So if you do an ultrasound, you might see there's thickening of the gallbladder wall. You might be tempted to call cholecystitis because these guys will have a stone. I think this patient has got a stone in here. CT is not fantastic for looking for stones because the pancreatitis is most likely caused by a stone coming out and passing through the common bile duct, which is here. But I think it's worth, with your ultrasound, you've really got to see focal tenderness of that gallbladder, okay, and make sure they don't have raised amylase lipase of pancreatitis, okay. So it is one of your false positives for cholecystitis is having acute pancreatitis. Also acute hepatitis, you see that quite often, return traveller, acute hepatitis. The hepatic aspect of the gallbladder wall gets edematous and thickened. You might confuse it for cholecystitis, but it's not, it's just reacting to the inflamed liver next to it. Okay, right iliac fossa pain in a 36-year-old female. Female is the key here. If you have a female with right iliac fossa pain, then ultrasound's a really good test because you're going to be able to look at the ovaries and the uterus, and you're also going to be trying to look for an appendix to confirm appendicitis. In a male patient, there's not a lot of things that are going to cause right iliac fossa pain. You might not necessarily try an ultrasound, okay? At least with females, the differential is really helped by the ultrasound itself, particularly from looking from the ovaries, confirming there's no torsion, there's no ruptured cyst, there's no blood sitting down in the pelvis, okay? This patient has the classic ultrasound appearance of appendicitis. So there's this blind ending tubular structure in the right iliac fossa. There's a hyperemia next to it, and it kind of gets these layers in it because the wall gets edematous. And on a transverse view, that was a longitudinal view, on the transverse view you get these multiple layers, hypoechoic, echogenic, and then hypoechoic again with surrounding inflammation. It's distended. Usually we use 6 or 7 millimetres as the normal transverse diameter for the appendix. If you're looking at this, it's focally tender, it's not compressible, it's hyperemic, it's distended, it's got this stratification of the wall. That's appendicitis. So ultrasound, very good when it's positive. If you can't find the appendix, obviously you need to go on to either further testing or just operating based on clinical suspicion. Here's a CT. Itis. So the wall of this appendix here is thickened. See how that's thick? Look at the wall of the bowel everywhere else. See how thin it is? The bowel wall is very, very thin when it's normal. This is the wall of the appendix. It's thick. This one's still got gas in it, hasn't completely resorbed the gas. It's got its own little mesentery, the mesoappendix, which is inflamed. See the fat around here? See how it's all grey? Look at the black fat over here, nice and black. So that's inflammatory stranding within the fat adjacent to this blind ending tubular structure. See, it just stops there, arising from the base of the cecum. This patient also had a massive renal cell carcinoma, so 2 for the price of 1. Coronal plane might be useful as well. Just to see that ileocecal junction is this little kind of projection that comes into the cecum here. That's where the ileum's coming in. Just look a couple of centimetres below that and you'll usually find the origin of your appendix. Okay. Distended appendix, blind ending tubular structure. Yeah, so you have, from Taiwan has asked, do you have tips for detecting appendicitis by CT in a thin patient or patients with very little fat plane? All right, so the answer to this is that it can be very hard when the patient doesn't have much abdominal fat because we're restricted in being able to detect that inflammatory stranding in the fat to really catch your eye. But that said, in most cases, even when they've got very little abdominal fat, that fat around the appendix in the setting of appendicitis will actually expand because it will get edematous. Edema brings in more volume, okay? So often you will be able to see it. The other thing is what I've just told you, finding the ileocecal junction, dropping down a couple of centimetres, finding where the appendix is likely to be arising. The third one, here's a case of a patient, 35-year-old male, tender left iliac fossa, and they were looking for diverticulitis. All right. So this was a case that was missed by one of our registrars. And as you follow this down, you can see this is the descending colon, the sigmoid here, looking for signs of, diverticulitis. We can't see any, okay? But what we do see is free fluid in this male patient's abdomen, in the male patient's pelvis. So in front of the rectum, okay, a little bit of fluid between it and other bowel loops, okay? Seminal vesicles you're allowed to have, then bladder. As you come up higher, a little bit of free fluid. That's the thing that I spotted when I was reviewing this study, and I went, male patient, free fluid in the pelvis, something's going on here, we've missed, okay? Next thing I thought of was, let me find the appendix, okay? And in this case, again, you want to try and find your iliocecal junction, which is better on the coronals, and then you want to look for a blind ending tubular structure. The reason why this was missed is because the appendix is massively distended in this patient. This is the appendix from here to here, coming right down into the pelvis. That's the blind end of it. This is the stranding around next to it, free fluid in the pelvis next to it, okay? So my tip for how do you find it, and this patient obviously has very little intra-abdominal fat and quite distended, fecally loaded bowel, which makes it hard. Coronal image is much better. You get a nice corresponding image to that target sign you might see on ultrasound, okay? But the key here is that free fluid. Detect that little bit of free fluid. In a female patient in menstruating years, you can have a little bit of physiological free fluid, okay? In a male patient, no free fluid is allowable. There must be something going on, okay? Final appendicitis case, patient here who has, so finding the small bowel coming in, that's the iliocecal junction there, looking a few centimetres down, you can see the origin of the appendix, a little bit of stranding in the fat around it, see that little bit of fluids, streakiness in the fat, a little bit of gas, which doesn't seem to be in the lumen, right? Here's the lumen of the appendix, locules of gas next to it. You track it up, here's another little bit of fluid sitting right next to the tip of the liver with locules of gas in it. When you're looking for free gas on the abdomen, so any of these patients with an itis, especially anything in the bowel, you want to be looking for any free gas to suggest that there's perforation. And you want to switch over to a lung windows or a bone windows to really emphasise the difference between the black mesenteric fat or omental fat and the black air, okay? You see this air sitting up next to the gallbladder here, little free locules of gas. So this is a sign that this appendix, locules of gas, has perforated. So a case of perforated appendicitis. This patient had a background history of Crohn's disease, which made it quite hard for the registrar to get Crohn's disease out of their mind as the diagnosis. This is the slightly inflamed terminal ileum. See how the wall's a little bit thick, a little bit of edematous. Okay, but the pathology here is definitely centred around the tip of that appendix. So the main tip is to switch it onto bone or lung windows, scroll through the whole abdomen. And obviously gas is going to go anti-dependently. All right, so it's going to sit against the anterior wall. Okay, so it's going to track up here. That's why when you're an erect patient, it's going to sit up here. All right. Gallbladder, we'll move on to gallbladder. Gallbladder is great for ultrasound, okay, better than CT. Okay, so if you're really thinking this is going to be biliary or gallbladder pathology, you should start with an ultrasound, okay. Gallstones, we saw earlier there was a gallstone in that gallbladder, very hard to see on the CT, but gallstones stand out really, really easily on ultrasound. I reckon these ones kind of look like angry birds. Anyone? So you get that echogenic stone and you get shadowing after it, okay, so posterior acoustic shadowing, all right. Here, the wall of the gallbladder you can assess really, really well because there's bile inside it, okay, so nice anechoic bile, and then you get a nice thin wall and then the liver sitting next to it. The liver helps, it gives you a nice window to look at the gallbladder. This is not the greatest spot to measure the wall of a gallbladder. You should always kind of measure things perpendicular to the way in which the ultrasound, the sound waves are arriving. You can get a little bit of variability out here. So you probably should be measuring wall thickness directly in line with the transducer. So gallstones without cholecystitis, okay? Normal thickness of the wall, probably not focally tender. No pericholecystic fluid is the other thing. So you get the wall can get thickened, but you can also get little bits of fluid next to it. This is probably a vessel sitting in here. The other thing you can see on ultrasound is you can track the CBD And occasionally, the main thing you want to see is whether it's dilated, okay? Because if it's dilated, there might be a stone in the common bile duct. And occasionally, you will actually see the stone. Here's an echogenic thing sitting in the common bile duct, and you can see shadow, posterior acoustic shadowing. Okay, so that is a case of choledocholithiasis. You often don't see the distal common bile duct because there's overlying bowel gas, all right? So you may get a study where you've got dilated, you've got stones in the gallbladder, you've got a dilated common bile duct, can't exclude choledocholithiasis. You might want to go on and do another test like an MRCP or a CT IV cholangiogram just to assess that, exclude a stone in the duct. So ultrasound good for that. Here's a case of cholecystitis. Again, we've got this stuff sitting in the gallbladder. It's not really shadowy, but a little bit of shadowing there on that image. And hyperemia of the wall of the gallbladder, thickening wall. Okay, so acute cholecystitis. Very, very easy to diagnose on ultrasound. Difficulty comes if you don't see any stones and you've got features of cholecystitis. As I said, in that situation, really think hard about pancreatitis or hepatitis and a reactive thing. Acalculous cholecystitis really only happens in really, really sick elderly people, diabetic people. Very, very rare. On the CT, you can obviously diagnose it on CT as well. I just want to point out again that the mucosal aspect of the gallbladder remains really, really thin enhancing, and then the rest of the wall gets this edematous appearance. Okay, so thickening of the wall, stranding of the adjacent fat. See how the fat next to it's all grey? So edematous, you can see a stone sitting in there. Okay. I'll just go back to that one. If you see non-enhancement of the mucosa, so you see a thickened gallbladder wall and you're not seeing any enhancement of the mucosa, that's gangrenous cholecystitis. I've missed that myself before because I didn't appreciate that you should always be able to see that enhancement. If you've got the right phase, you should always be able to see that enhancement of the mucosa. Okay, and we're moving on to diverticulitis. Again, we're looking at the same kind of thing. Bowel loop, the wall's too thick. Look how thin the wall is over on these other bowel loops. Okay, you've got some reactive thickening of small bowel loops next to it, stranding in the mesenteric pericolic fat. Really, really thick segment, quite a long segment of sigmoid, which is thickened. What are you going to do? You've got an itis in the sigmoid. It's probably diverticulitis. You've got to make sure they haven't perforated. Switch it onto your bone or lung windows. Have a look from the top. Gas is going to track up to the top. Okay, little locules of gas sitting in the wrong spot, perforated, acute diverticulitis. It's got a little bit of a collection just here, so you can see the sigmoid coming through there. You might not see the actual diverticulum that's inflamed, that's caused it, that's triggered it off. All right, you might just see generalised thickening. You can probably see some of these little things are diverticuli coming off here. You just see general edema of the wall, thickening of the wall, and then adjacent to it you've got this fluid, this collection with fluid and with air in it. So itis, thickened, inflamed fat around it, easy. Left-sided abdominal vein with guarding and rebound. Now this is the differential diagnosis for, or one of the differential diagnoses for diverticulitis. This is a little tricky one. You see this thing which you think, oh yep, there's lots of inflammation next to this descending colon near the junction with the sigmoid colon, and they've got diverticuli. There's little bits of gas sitting off the edge of this sigmoid, so they have got diverticular. And then as you come up here, you notice this big inflamed area stranding around it. The key to this one is that it's got central fatty density. See that fat? It's the same density as the fat next to it. That's called epiploic appendigitis. So this is a benign kind of self-limiting thing, doesn't need any treatment like the diverticulitis. Okay, so that's a little tricky one. Again, that's one for radiology registrars in their exams to be aware of, epiploic appendigitis. This patient was hospitalised for pneumonia and now has increasing abdominal pain. So presumably they've been on antibiotics for their pneumonia. So itis involving the colon, you can see how you've got the, come down, you see how you've got that nice, same as we saw with the gallbladder, the mucosa, nice thin enhancement, then the wall, edematous, okay? So you don't have to think too hard to go, it's in the colon, it's fairly diffuse. I'm going to call this colitis. Okay, not a lot of stranding in the fat around this, but a very gross colitis involving the whole of the sigmoid. Okay. In a patient who's on antibiotics, this is the typical appearance of pseudomembranous colitis, so an infective colitis related to the antibiotic treatment, getting rid of the normal gut flora. Okay. But it's the same, any itis anywhere in the colon, it always looks the same. All right. Ulcerative colitis could look like this. Okay, ischemic colitis will be in a different distribution. But the key is to recognise the thickening of the wall and stranding of the fat adjacent to it. Okay, severe epigastric pain. Another itis. Here you go. Just to emphasise again, mucosal enhancement, thickening of the wall. This one's at the pylorus, or first part of the duodenum. A little bit of gas sitting out in the wall. So this is a locally perforated peptic ulcer. But again, it's the stranding of the fat around it. It's the thickening of the wall that catches your eye. People often ask why we use oral contrast for CT scans, and the answer is that most of the time it isn't useful at all. It's really useful for delaying a scan if you don't want to do the scan. Okay. Oh yeah, they'll need oral contrast and then skedaddle home and someone else will have to report it. But it is good in some situations, especially in this kind of setting where you have got oral contrast which is leaked out, okay, and you can actually see a hole in this patient's stomach where the oral contrast is leaking out, okay. It can be good in a small bowel obstruction to help you find a transition point because the contrast will go down towards it, okay. But most of the time, a small bowel, a positive contrast for a CT of the abdomen is not of great use. All right. This has got, you know, huge amount of free gas in this patient's abdomen. A good example of why you see Wriggler's sign, okay, air on one side, air on the other side. So you'll detect that interface on your plain film. So 30-year-old male with right-sided abdominal pain, question mark ureteric stone. What are your findings? Quiz case. And the winner is Alyssa.
Hi.
Are you going to come down?
Okay.
Oh, excellent. Then you,
Wine involved.
yeah, there's one. I think, I said with CTPAs earlier, I thought it's a good idea for ED doctors, ED staff to be able to trace the vessels, find the PE, because it's a single job, single task. Same with renal colic, renal stone, or ureteric stone. One task. I think they've got this. Let me try and find it. Okay. Do you want to come and find it?
I think I was drinking wine when I did this.
Okay.
So I'm not
Watch
sure
out,
if I
watch
can
out for
remember.
this.
All right.
Little trick with our website. Often the abnormality is on the very first slice.
So I thought that was a stone in the ureter. Sorry,
Yep.
in the VJ.
And what about this one on the other side? What do you think of that one?
I think that's too far out.
Yeah. So what I want to point out on this slice here is a thing called the soft tissue rim sign. So here it's the same with the bowel, with the itis. Okay. This is a stone that's sitting inside the ureter. The ureter is usually a very thin-walled thing. If it gets inflamed, it's going to get thick-walled. You're going to see soft tissue density all the way around the stone. See how there's that grey? It's not fat density, it's grey. Okay. Look on this side. This little calcified thing, it's got fat density all the way around it. That's what a phlebolith looks like. Okay, so this is called the soft tissue rim sign. One little trick to help you, but the main thing you should be doing is tracking the ureter from the top. What did you think of this guy's kidney or kidneys?
This was the duplex one. I think
Yeah,
the
horseshoe.
horseshoe shaped. Yes, sorry. So yes, they're obviously joined. They're.
Yep. So the lower pole of these kidneys is joining across the midline.
I want to scan it.
So a horseshoe. Yeah, you want to do an ultrasound.
I want to do an ultrasound.
Hydronephrosis on this side. See this renal pelvis coming out here? Okay, on the other side, much smaller renal pelvis. You can follow the stone all the way, the ureter all the way down here. You shouldn't be able to follow a ureter that easily. Okay, if you can follow a ureter, then it's got hydroureter. It's also got some stranding around it. See how that little fat is inflamed? You follow that ureter all the way down and you find the stone. You should be able to trace a ureter on every patient who has an actual stone. If they don't have a stone in there, you may struggle to follow it. But if they do have a stone, you will be able to trace it. You can get a prize. Well done. That's just a zoomed up version of that soft tissue rim sign. Phleboliths in the pelvis are very common. Have a look at this. Look, there's 1, 2, 3, 4, lots of little calcified densities on the other side. These are little pelvic veins that thrombose off and form a little thing. They can have a comet sign where, so on one side you could have a little bit of density tracking into it, but they should have mainly fat sitting around them. Okay, here's another patient. You should be able to tell from the first few slices. I can tell if patient's got a ureteric stone from the top of the scan like that. You say, which side is it on? They've got left pain, haven't they? I can see stranding of this kidney. It's an itis. It's bigger than the other kidney. It's got stranding of the perirenal fat, and I can see dilatation of these calyces. Look at this. Calyces are tiny on this side, surrounded by fat. This side, big calyce. Okay. Coming down, ureter, tiny little ureter on one side, big ureter on the other side. Follow it all the way down, and you will discover your stone. Okay, very common site to get it stuck, the fasciculoureteric junction. Measure it. 5 millimetres is usually the size they're interested in. There's a chance that a 5 millimetre stone won't pass by itself. If it's less than 5 millimetres, they almost always pass themselves, don't need any intervention. Okay, is the patient septic is a very important thing. A septic obstructed picture needs an urgent nephrostomy tube stuck in. I reckon it's important to measure them in the coronal plane as well, because you often get way above 5 millimetres if you look in that plane. In the axial, you might not get to that level. I'm not sure which is the one that is the more important dimension. We scan all our patients prone for renal colic here at the Alfred, and that is because, I'll show you the next case. I'll come back to that in a moment. Ultrasound, again, very, very good for looking at the kidneys, because it's very good at looking at fluid. Okay, this is hydronephrosis. It's a beautiful correlation with what we're seeing on the CT. The echogenic stuff here is the fat that's being displaced by this anechoic fluid within the calyces. Okay, you don't always see the stone on an ultrasound, but you will see the hydronephrosis. So if you screen someone, and there was a study recently, I think, published in maybe New England Journal, can't remember for sure, which basically compared ED physicians and sonographers doing a scan, an ultrasound scan, and then after that deciding whether they needed a CT or not. And they showed that the management of the patient was exactly the same in terms of outcome, pain scores, days in hospital, all those kind of things, and they avoided around 50%, I think, of CTs that would have been performed otherwise. So ultrasound is definitely worth doing. You occasionally do see a stone. Here's an example at the VUJ. You see that little echogenic thing and the shadow behind it, all right? But not being able to see the stone, but you can do this thing, which is where you put on your colour Doppler over the ureteric jet. Here's the right jet, spurts out, you see it really easily. The left jet is not going to be spurting. Okay, so if you've got a hydronephrotic kidney and you've got a jet where you can't see anything coming through and the patient has symptoms of ureteric colic, then you've pretty much got a slam dunk, all right? You don't necessarily need to get the CT unless things that go on continue on. So here's another example of a patient that's why we scan prone. Have a look at this thing. It looks like, for all intents and purposes, it looks like this thing is sitting within the bladder, right? See that? The bladder wall's here, this little thing sitting here. If this patient was scanned supine, you'd expect that. You'd expect it to fall into the bladder and then it sits at the back of the bladder. That's perfect. Gravity will pull it down because it's more dense than the fluid in the bladder. But in a prone patient, that stone will fall down to the front. If it's clear of the fasciculoureteric junction, it will fall to the anterior bladder wall. So this stone has not completely passed hydroureter on that side. That's why we scan prone. Not everyone does it, but a lot of places might review the scan, do a scan supine, and then review it. And if they see one doing that kind of thing, they may do just a small section of prone imaging at that spot. Here's an example of one that has passed through, right? Stone sitting against the anterior bladder wall. Come up from the top, you can see a little bit of hydronephrosis on this side. You can see stranding around the ureter. So they've definitely recently, still a big ureter, they've definitely recently passed a stone down the left-hand side, okay? So that's a good reason to scan people prone. If you don't do it at your institution, then it might be worth switching over. The other thing to say about renal colic is that we do it as a non-contrast study, so there's no intravenous contrast. And it's so that you can detect those tiny little stones. You can see the density difference much better. If you've got IV contrast on board, kidneys get a little bit bright. The kidneys take a lot of blood flow. They get very bright. It can be much harder to detect the stone, and you don't need contrast to detect a stone. Okay, here's a complication of having a stone. Here's a stone at the PUJ, so the pelviureteric junction, which is another common spot for it to get blocked off. Hydronephrosis, gas within the kidney. Okay, this is a medical emergency or a surgical emergency. It needs to be drained. That's where an interventional radiologist will come in handy. Use a needle to get a little catheter into the hydronephrotic kidney, and then basically stick a pigtail catheter in there, drain away that pus, and then take a photo of the pus. But that's an emergency. That kidney's going to die. It's got gas and pus sitting in it, right? Unless you can quickly drain that away. So that patient was, I think, diabetic, and this is just a nice, quirky little film. A patient who's elderly and diabetic and presenting with delirium, abdominal pain, non-specific. Nice example of small bowel. See how closely packed these little mucosal folds are? See this linear, curvy linear outline here? This was emphysematous cystitis, so gas within the bladder wall. So it's very rare, okay, but just a cute plain film one. If that comes up in an exam and you get it right, credit me, because that's a... All right, 60-year-old male with abdominal pain and vomiting. What are your X-ray and CT findings? We're moving into the obstruction part of the presentation. Dan, where are you? Daniel. Daniel was the winner for this one. And we got a question from Anna in Israel. More tips about small bowel obstruction. This is the biggest request we had was, how do I find the transition point on a small bowel obstruction? Okay, so I'm going to go through some tips. I'm going to use this case. All right. Now, everyone, when they were assessing this plain film, were able to identify that this looked like a small bowel obstruction. Central loops of bowel that look distended. They've got folds that are very close together, telling you that it's small bowel. Multiple air fluid levels on this erect film. This is like the string of beads kind of sign here. All right, so that's little bits of fluid sitting up high in that nearly completely fluid-filled bowel. Okay. Supine radiograph, again, just distended small bowel loops. They've had surgery before, a couple of pelvic sidewall clips. So Daniel spotted all those things, and Daniel spotted the transition point on the CT, but he also spotted the other background disease that this patient has, which is?
Ankylosing spondylitis.
Yeah.
And so you can see it on the dagger spine appearance, that's calcified interspinous ligaments.
Correct. So this patient has just a nice film with that supraspinous and interspinous ligaments ossify in ankylosing spondylitis, creates that dagger sign, and also the bamboo spine of the syndesmophytes fusing, and you can't see the sacroiliac joints, completely fused. So that was just a nice multiple findings kind of study. I'm going to move on. Take your prize, Daniel. It's the kind of case they give the registrars in their exams because they get distracted by the acute presentation and might miss some of these obvious background diseases. All right, so how do you find a transition point on small bowel? Well, the first thing, small bowel obstruction. First thing is, are the loops dilated, right? These are dilated small bowel loops. That's easy. Multiple fluid levels. You can probably identify why you had that string of beads kind of appearance, because you can see just little lockers of gas sitting up here. That means that bowel's not moving. It's got ileus in it. It's aperistaltic if you've got multiple fluid levels. So dilated. Next thing you do is go down to the terminal ileum, okay, and confirm that they're all collapsed. Look at this bowel here, completely collapsed in on itself. Okay, so we've got collapsed loops of bowel down in the right iliac fossa. Terminal ileum's collapsed. We've got proximal small bowel, which is dilated. So there must be a transition point. Hernial orifices is a great place to look. Look for any umbilical hernia. Look for any femoral hernia. A little bit of fat coming into this right inguinal canal, but no herniation of bowel. There's funky little hernias like obturator ones, and that's not the obturator. That's the obturator. Spigillian hernias. So have a look for those. But then my number one tip, the patient who's had prior surgery, it's probably going to be an adhesion. Okay. Look for feculent small bowel. Okay. So feces within the small bowel always develops at the point of obstruction or just before the obstruction, okay? So if we're looking through all these bowel loops, we're seeing that most of them have just got nice simple fluid, air fluid levels in them, and as we come down here, we notice little locules of gas sitting in there. That's fecalization of the small bowel content. So it looks like feces in the large bowel here. That's where your obstruction is going to be. If you follow that, fluid, 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 forming feces, nice beaking here, and then collapsed loops coming away from it, okay? So that would be my tip. Confirm that you're dealing with something that's completely obstructed, distended proximal loops, completely collapsed distal bowel, and then look for fecalized small bowel. Now, it does take a little while to develop that. So if you have a very sudden onset obstruction, you're not going to push stuff along to the point where you start to get resorption of fluid and fecalization. It's usually, subacute kind of setting, but it's definitely worth looking for. You will see it in most patients. So here's another example, gallstone here. We've got, look at all these collapsed loops of small bowel down in the right side of the abdomen. Okay, so we're definitely dealing with a transition point. We've got lots of distended small bowel loops up here in the left upper quadrant. Fecalization of small bowel here. Okay, follow that down, stops there, and then it transitions into those collapsed loops. So if you want to find the spot, look for the feces within the small bowel. Okay, final case of small bowel obstruction, I think. Distended loops, completely collapsed loops down here in the pelvis, heading back to the cecum. Okay, so you know there's going to be a transition point. Looking in your hernial orifices. See this fecalization of the small bowel here? It starts to get little locules of gas within it. Just before it heads into this femoral hernia, and then you've got collapsed loops coming out of it, okay? So look for hernias. Differentiating between femoral and inguinal hernias. Femoral hernias are more, tend to happen in women. It's located out lateral to that pubic tubercle, whereas an inguinal hernia will continue and come towards that. And femoral hernia almost always compresses the femoral vein. Look at that. See that vein squashed? Artery here, vein completely squashed by it. So that's in femoral canal. An inguinal hernia won't tend to squash your femoral vein, okay? Okay. Now, there can be some tricky bowel obstructions. This patient's got definitely very collapsed loops of small bowel here. The proximal small bowel is not ridiculously distended, okay? But then you get to this one segment here, which is very, very distended small bowel. Nice mucosal folds telling you that's small bowel rather than large bowel. And it's all coming back to this point here. See that collapsed bowel coming in? So that's a transition point. But it's not distended proximally to it. It's all just one little segment. So that's a closed loop obstruction. So there's two little things, one bit of bowel coming in and one bit of bowel coming out of this closed loop. This patient had surgery before. There's a little tear in the mesentery allowing this to herniate out. All right, this is, these ones are susceptible to getting ischemic. Most small bowel obstructions don't, but when you've got a closed loop obstruction, the vessels have to pass through that narrowing as well, and so you might get ischemia. Anytime you have a small bowel obstruction and you've got fluid next to the bowel loops, I'm worried about ischemia. All right, so fluid next to small bowel, the bowel is inflamed, okay? Then you're looking at the mucosa of this patient. I'll do it on the axials. Looking at the mucosa, see the nice mucosal enhancement on all these loops coming around to here, and then suddenly can't see any mucosal enhancement. See that loop? Nice mucosal folds enhancing. So that's an ischemic portion of bowel, okay? So the fluid next to it is something that tells me, oh, this is not good, okay? It's not your standard small bowel obstruction, and then looking for the mucosal enhancement. Here's an elderly woman, and this is just to show you what ischemia does when it gets really advanced. You get this gas coming through the portal veins, portal system up into the liver. Because the portal veins pushing into the liver, it tends to go out peripherally like that, whereas in pneumobilia will tend to be some gas within the hilum, the porta hepatis. This patient's got chronic disease going on here, the past history of pancreatic cancer, all this tumour engulfing their superior mesenteric vessels, okay, causing the ischemia. The bowel, non-enhancing, okay. Gas within the wall of the bowel, see that gas sitting there? You're allowed to have gas that sits antidependently, it sits antidependently, but this gas sitting down the bottom, beneath the fluid, shouldn't happen. It should always track up. So that's gas within the bowel wall, intramural gas pneumatosis, okay. So this person is pre-terminal. Your bowel's dying, the patient's probably not far behind.
Let's make one comment about the ischemic bowel, Andrew. So, CT, so key point with ischemic bowel is a negative CT and a normal lactate and a normal white cell count does not exclude ischemic bowel. So, no biomarker has been shown to be sufficiently sensitive to exclude it. Lactate, I've seen a couple of patients die with normal CTs and normal lactates. And if you look, there's quite good retrospective sort of meta-analysis studies comparing those intestinal fatty acid binding proteins. Now, there's all these other biomarkers that are trying to find the golden bullet for ischemic bowel, and there isn't one. So if you've got a geriatric with abdominal pain of relatively sudden onset, don't send them home with the diagnosis of constipation if their lactate's normal and their CT's normal. If they've still got pain, they've still got ischemic bowel, just hasn't declared itself yet. The markers are great in late disease, but what happens most days now is patients come straight in, they get a scan within an hour of arriving, they get their bloods back 2 hours later and goes, I don't know, it's all normal. Surgery says, no, I won't see them. Send them home, or put them in short stays. The other great place they end up is the geriatric abdo pain assessment unit, and you just got to maintain your index of suspicion. Go with what the patient tells you. If they've still got pain, it's not excluded.
I think that is reflected in the way we report those scans as well. Yeah. It's very common for us to say ischemic gut is not excluded in our report because it can look, we know that it can look perfectly normal.
Your odds are dropping, but normal scan maybe 90%, normal lactate maybe knock another 10 or sort of 80-90% out, but you're still going to have a few percent that have infarcted gut. It just hasn't declared itself.
So this woman here has got a short segment, a relatively short segment of small bowel, which is thick-walled, a little bit of inflammation of the fat around it. Okay, and this patient has thrombosis within their superior mesenteric vein. So it's not necessarily on the arterial side. That woman had arterial involvement from that pancreatic cancer. You can get thrombus on the venous side, which leads to significant ischemia of the gut. Okay, so it might be related to taking the pill or hormonal replacement. Abdominal pain and distension. Last little thing before we have lunch is the large bowel obstructions. This is a very big, distended, viscous, sitting centrally within the abdomen, okay? You're all going, oh, is this a cecal volvulus or a sigmoid volvulus? If your cecum twists on itself on its little mesentery and distends up like this, no gas is going to get past it, so you're not going to have distended large bowel distal to it. So you can see in this patient there's no real distension of the rest of the large bowel. See the descending colon here, a little bit of feces in it, but no distension. So that's a good sign that we're talking about proximal large bowel that's distended here. And also it doesn't have that coffee bean or three lines. A sigmoid volvulus usually has one line here, one line in the centre, and another line out here heading down to that left iliac fossa. So this is a good appearance for a cecal volvulus. On CT you can relatively easily determine it. Remember, you only get volvulus if the structure is on a mesentery, okay? The cecum has a variably sized mesentery. Sometimes it's big and it can volve, okay? So here's the very big distended cecal segment, and look at that beautiful twist as it comes out of there, okay, into collapsed. The rest of the large bowel's got feces in it, but it's relatively collapsed. I love this annotated image on the site because it just says, it's so like, cecum, twist. So Mark Holland, very good annotated diagram. We should have that for every case. Really ram it home. So this is the sigmoid volvulus. Just have a look. Firstly, you've got those three lines, one line out here, a line in the centre, and a line out here, creating that coffee bean kind of appearance. The central kind of line in the middle of a coffee bean, all pointing down towards the pelvis. But have a look at the large bowel proximal to it. See this? That's the descending colon filled up with gas, right? It's a bit distended. Gas over here. So if you've got if it's sigmoid volvulus, yes, you're going to have that pattern that you might recognise, but also you can have distension of the large bowel proximal to it. Okay. On the CT, you can follow your descending colon down, and you'll find that it goes into the suddenly distended sigmoid colon. Follow that right up, and it's going to come down to exactly the same spot and collapse down to nothing. This patient's had rectal contrast put in, which can be useful in determining whether there's a complete obstruction or not. See how it tapers down and then goes into that same spot as well. Okay, so a nice example of a sigmoid volvulus twisting on its mesentery, the inlet and the outlet obstructed, closed loop obstruction. Looking for that gas on the anti-dependent side, looking for signs that it's ischemic. You know, there's not much free fluid in this patient, if any, right? So I'm not concerned. This is seminal vesicles here. I'm not concerned that this is ischemic at this stage. There's no gas in the bowel wall, no portal venous gas, but it obviously needs urgent decompression. The final one, the other cause of a large bowel obstruction, this one has got lots and lots of fecal loading of the large bowel, and you might be tempted to just give this patient constipation and send them on their way. Not sure what surgery they've had in the past, but they were investigated, and you can see this sudden transition from that fecally distended descending colon and sigmoid, and then you have this sudden thickening of the wall, narrowing. It's a very short segment. It goes through to here again. It's only a very short. And if you imagine if you put contrast on that on either side, you'd get that nice apple core appearance. You get shouldering, proximal shouldering. So that's a very focal circumferential thickening of the wall. So that's a bowel cancer presenting as a large bowel obstruction. So distal large bowel lesions very commonly present with obstruction. Proximal large bowel cancers often present with anemia. Okay. So you can see that in other planes as well. It's just a nice look at that. Short segment thickening obstruction proximal to it. You can see exactly why you're going to get that apple core appearance on your old style barrier minima. Okay, I think it is just about, it is 1 o'clock. So I was going to finish with vascular stuff in the abdomen. First thing to say is that abdominal aortic aneurysms are really obvious when they rupture. You barely even need contrast in there because you're looking for this retroperitoneal hemorrhage. Okay, easy, don't need much help diagnosing that. Just get an urgent CT scan and you'll get the answer. This is more subtle. This patient's got abdominal pain and an abdominal aortic aneurysm. This is the mural thrombus that sits within the aorta, within the aneurysmal sac. And you want to look, you want to see a fairly uniform density in it. If you see this peripheral hyperdensity, that means that blood is currently slowly being laid down into it, okay? This is a sign of impending rupture, okay? So important to look at the density of the mural thrombus within your abdominal aortic aneurysms. This may be getting rapidly bigger and be about to rupture. This final vascular case, if you have a very irregular, lobulated looking aneurysm, okay, and you've got here some fluid collection sitting in the adrenal gland, fluid collection sitting in the diaphragmatic crus. This is a mycotic aneurysm, so an infected aneurysm. It's occurred in a funny spot. They're always very irregular like this. These rupture the wall out one way and you get these collections next to it. This was Staph aureus. Nice example of reactive lymph nodes next to it. Enlarged lymph node. Looks like a kidney, just a small kidney. Right. Nice fat coming into the centre of the hilum of the lymph node and a reniform shape. Lunchtime.